Even if there are some things that the biotech sector wants to develop over time, again, our mission is to accelerate that. So what we're, spoken with members of Congress, what everybody agrees on, no matter what the party is it takes too long to have health solutions. Everybody wants a faster response.
Hello and welcome to Washington Post Live. I'm Frances Steed-Sellers, a senior writer here at the Post. Today we have two sections on technology, innovation, and cancer. And later on, I'm going to be joined by Dr. Eric Topol of Scripps Research. But first of all, I'm delighted to be joined by Dr. Renee Wegrzyn, who is the new director of ARPA-H, the new agency founded in 2022. Director Wegrzyn, a very warm welcome to Washington Post Live.
So much for having me, Frances.
We're delighted. And first of all, so ARPA-H was established in 2022. I think you had $1 billion budget then and are asking for a lot more right now. Tell us what the acronym stands for and also what the point was behind creating a new agency.
Yes, so ARPA-H, or the Advanced Research Projects Agency for Health, that's a nod back to DARPA, right? The Defense Advanced Research Projects Agency. So we're
I think we may be having a little problem here with sound. We will be back with you soon. We're having a little technological problem here, but we'll be back with you soon. Not hearing anybody. Mohammed, I'm not hearing.
Can you all hear me okay?
And we'll be back shortly. Delay, we are back with Dr. Renee Wegrzyn. And let me repeat the question, which was about ARPA, funded in 2022 with $1 billion of funding. And I wanted you to explain to us what the acronym stands for and also what the idea was behind creating a new agency.
Yes, ARPA-H, or the Advanced Research Projects Agency for Health, was really launched with the idea that we need to create a new agency to augment the existing health ecosystem, but to move in a way that's more like the DARPA business model. So this is a nod to the original Defense Advanced Research Projects Agency that could go after these big, audacious goals, but be able to move forward with very little bureaucracy and with business models that can demonstrate prove that something is possible in health, and then transition very quickly out of the agency into the real world. And so that's what we've been doing this past year to help get this started. We actually have had a second appropriation, so we're now at $2.5 billion.
And you're asking for more for next year, correct?
We would love to grow. Yes, absolutely.
Okay. Okay. So you mentioned DARPA, but I'm curious about what you see was lacking in other, or what people behind the whole invention of ARPA see was lacking in other agencies.
Yeah, so there's a few things that I think there's a lot of incredible work happening across the health ecosystem, but where there were a few gaps was just the speed at which an innovation is happening, but there's a lack of really the ability to contract and bring new efforts into existence in the federal government to move very smoothly. And this is where some of our authorities from Congress have been given to us to use things like other transactions, a little bit of government jargon, but really what this means is creating contracts that feel more of like a business to business interaction rather than a government to business or a government to academia, which can be a little bit of a slow process. And so streamlining that has been important. One essential part of that is also how we make decisions. So our program managers, these are the leaders that manage our investments going forward. They have a lot of autonomy and are the sole decision maker. So they do take perspectives from experts in the field, but unlike counterparts such as NIH that uses large external study sections to weigh in on proposals, we can take those big risks because we have a much more lean decision-making process going forward as well.
So I'm thinking globally here. America has been the innovation capital of the world. There's no doubt about that. But federally funded R&D is in decline. Is America losing that prime spot? What's the big picture here?
Well, I would argue that ARPA-H is a great opportunity to make sure that we don't lose that prime spot and that we can really meet at the speed of relevance. But what has really lagged is this bridge between innovating in a laboratory or a company and then getting it out into the real world. And so some of the foundational work that we've done in this past year is twofold. One is at the very beginning of projects to make sure that we are listening to our customers. Those are the patients, those are the healthcare providers that may use our tools. Make sure we are designing for them, solving real problems that matter to them. And on the other side, making sure that we are engaging early with investors, whether that's the private sector again, or other parts of the federal ecosystem to sustain our investments and our progress longer term. And so this is really looking at it very holistically, but making sure that our innovation can really continue to allow the United States to be dominant and innovating, but also share those innovations with the world.
So that really brings me to a big question. How do you measure success when you talk about biomedical innovation like this?
Is that if we're successful, if you even just think back to DARPA on day one, Eisenhower stood up DARPA. He wasn't saying 8 years from now, we're going to have the internet. And after that, we're going to have stealth technology, right? So for us, the way that we're measuring success is if we have these moonshots that will be realized in 15, 20 years, what are the metrics and the milestones 1 year from now, 2 years from now that help us understand that we're on track? Demonstrating that something that seemed completely uncertain or improbable is actually possible, and start to gain those insights is key for us. And so every new program that we launch, for example, our first program, which is focused on osteoarthritis and having joints heal themselves, all across the way, we're looking in early days, can we manufacture the cells? Can we demonstrate that they're effective? Then can we bring these into the clinic, and can we have positive patient outcomes? These are all measures that we will uniquely assign to each and every project that's launched by ARPA-H.
So Renee, we want to talk specifically today about cancer and talk about any of the moonshots that you have launched specifically with cancer in mind.
Yeah, So what was interesting is that in many ways, ARPA-H was inspired by the original Cancer Moonshot, where it showed that a government project with people really focused on specific problems and goals can make significant progress to changing the course of disease in this country. And so ARPA-H is really intended to launch many moonshots, but including addressing some of the objectives of Cancer Moonshot. However, it's important to note that our dollars aren't linked to any specific disease or technology. So on our terms, looking for those investments that are very unique to ARPA-H that the private sector can't do because they're too risky, we've landed on a few projects that we're very excited about. So one is a program called Precision Surgical Interventions, or the PSI program, that brings together innovations in new imaging technology, but also visualization of those tools. Because during surgery for solid tumors today, a surgeon really looks into that surgical cavity in a patient, cuts away at that tumor, and then takes a slice and gives it to a pathologist down the hall and says, did I cut everything out? Did I get it all? If the answer is no, they go back in and they keep cutting more. You can already imagine how inefficient this is and how this also leads to many reoperations for patients and negative outcomes. It could also lead to damaging healthy tissue. So believe it or not, during surgery, cancerous tissue looks like healthy tissue. And so unintended consequences such as nerve damage can be a really big problem. So this program takes those innovations in imaging, in new visualization tools for the surgeon, and really allows this all to happen in real time during operations. And so that's the goal that this program has set out. And they're now selecting the teams that will demonstrate that this is possible and bring that innovation forward. One other example I'd love to point out is a project called Curate, which really takes advantage of some of the mRNA technologies that you've heard so much about. Of course, many of us have doses of mRNA vaccine in our arms right now. And that mRNA can actually be reprogrammed to do many things. The private sector is looking quite a bit at cancer vaccination. But what we were interested in is a project to actually use mRNA coded tools to actually directly target genes and either tune them up or tune them down. And in this way, you can actually tune your immune response, whether you're responding to a cancer, or you could use those same tools to respond to an autoimmune disease, or even to things like long COVID. And so some of these investments we know will be useful for cancer, but will allow us to actually make breakthroughs in other areas as well. And so I could go on, but those are just a few of the initial really bold ideas in cancer that aren't being addressed elsewhere that ARPA-H can seed and advance the state of the art.
You know, I wanted to sort of get a sense of this. You've talked a lot about the private sector, but also with philanthropy. Just today, the Rockefeller Foundation, announced a $1 billion climate action, people-centered climate action. Earlier on this program, I spoke to actor Robert Downey Jr. about his FAST grants for climate, both climate examples. And then there was a FAST grants set up, I think, out of George Mason University during COVID. How do you see philanthropy either complementing or competing with what you're doing now?
Well, if we're doing our job right, we're absolutely not competing, right? There's plenty of problems in this world. We absolutely have to work together to advance those goals. But importantly, ARPA-H investment is transactional. We are here to take on the riskiest things. Like when I think of venture or philanthropy, sometimes what venture might say to a group is, you know what, I'm not ready to fund you now, but come back once you've demonstrated X. We want to fund X. We're willing to take those early risks so that when we can tee up that funding downstream, whether it's from philanthropy or venture capital. And we're doing this in a more formal way in that we've actually just launched what we're calling an investor catalyst hub to, even early days, bring in investors, whether they're philanthropic or otherwise, to our program managers as they design these programs to understand not only what are the technical risks, but make sure that we do a market landscape analysis to say, okay, in addition to these key players, here are the risks that we need to address on the investing side, or maybe it's a regulatory risk that investors need to see de-risked to pick up those projects downstream. And so we're working very closely. In fact, I'm joining you now right after a Milken event here, again, with a lot of philanthropists here. are really trying to find creative ways that we can move forward. I love that you mentioned, fast grants and some of these other ways. It's actually really hard to work with the government, and this Investor Catalyst hub, we've also designed it in such a way. We want it to be simple. We don't want you to have this sophisticated grants writing shop as a requirement to work with the government. We want to work with small communities. We want to work with 3-person startups. And we want to make it as simple as a form fill on a website to work with us. And that's really what we're striving for.
I've got so many questions. I do want to ask you about the potential for innovation in this country to get held up in development or not to scale once you come up with these great innovations. And it's particularly true, it seems to me, in health, that America time and again comes up with the great ideas, and then in healthcare, it doesn't get spread across the country.
That's right. And we did the exact same thing. You're addressing some of these gaps as we are standing up this agency. We said, what are the things that are just fundamentally a blocker to prevent really a resilient healthcare system, for example? One of those is scale. And so we actually, one of our focus areas for investment is a technical office called Scalable Solutions. We are hiring a leader for that office. So this is a great platform to invite folks that would love to come to government and just demonstrate that scale. How do we get things out of the lab really scaling in the real world and in a cost-effective and accessible way that everybody can reach them, whether you're in a rural setting or you're even at home hundreds of miles away from a healthcare center. That is a place that we know there's a tremendous gap that we want to make sure we're addressing. And then fundamentally, this nationwide network that we're calling ARPA-H, we have launched to bring together our innovators at ARPA-H, our program managers, the teams that we fund with communities all across the United States, to partner with them and demonstrate, sometimes at a very small scale. Maybe it's at the scale of a home or a hospital, to show that it's possible, but then have that connectivity across this network to then really spread this as quickly as possible. If it's a great innovation, we've got to get it out there.
So back again specifically to cancer and this issue of equity, which you raised, is your goal ultimately to cure, eradicate cancer, or to diagnose it more quickly? Or give me a little bit of a picture on how you're coping with that, with these huge health inequities that now exist here.
So to say something like I want to cure cancer is a tremendously bold statement, and it wouldn't be kind of the typical way ARPA would approach a challenge. Instead, we would say, what are the blockers to getting to those cures? And some of that is scale. Some of that is the ability to be able to make genetic therapies in a cost-effective way and in a more universal way. And then the other would be, for example, personalized therapeutics for very, very rare cancers where you don't need 1 billion doses. You need one dose, and you need to be able to get to a patient very quickly. And so each one of those represents a program that we could initiate and launch around those areas to solve the barriers that would be presented. And if we're successful, we'll be able to, really buy down that risk again. So whether it's a company, or maybe we even launch a company to do this, would be able to pick this up, take this into the clinic, and make this a reality.
So Renee, ARPA-H's stated goal is to improve health outcomes. We at the Washington Post have just done a deep dive into life expectancy, and for years and years, people have, said that primary care is the area we need to put money into. They actually don't talk a lot about innovation or high-end tech here. It's the most basic forms of entry-level care. Tell us about where you think ARPA-H could help in that. HHS came out just yesterday with its initiative to strengthen primary care. What can ARPA-H do to turn around America's huge decline in life expectancy?
Yeah, so we saw the article here at ARPA-H from the Washington Post and passed it around because I think it's such a great example of some of the gaps that still remain that we must address. Life expectancy, not just across this nation, but as we've traveled around the country, it really has struck me how many towns we've been in where literally you could be, Chicago is a great example, the south side of Chicago, you look to the north side of Chicago, and there's a 20-year gap in life expectancy literally across the city. And so how are we in a hyper-regional way starting to demonstrate pilot experiments to show that we can make progress against not just life expectancy, but better quality of life, and then scale that across the nation would be one example. You mentioned primary care. This is a place we've talked to a lot of primary care physicians, and what they all want to do. They're like, I came into medicine because I want to help people and I want to engage with people. I spend a lot of time writing in these electronic health records? How much more of that can you automate and really help me refocus on the patient? And so this is an area through our investments in things like the biomedical data fabric toolkit program, where we want to automate as much as we can some of the more mundane and standardized tasks, and leave those specialized tasks, whether it's a healthcare provider, a primary care physician, or a surgeon, let them focus on and be at the top of their license when they're performing their profession. And so these are initiatives that we've just launched, and you should start to see hopefully some solutions coming out of those in the coming years.
A very quick last question, and it's a big one, I'm afraid. President Biden said he wanted to cut cancer death rates by 50%. How optimistic are you? And I'm afraid we're running out of time, so a quick answer.
Yeah, well, just like any moonshot, you have to shoot for the moon and try everything
Yeah.
you can to get there. And sometimes you will fail, but if you're shooting for the moon, even if you get halfway there, that's tremendous progress. And so every single one of our projects, we will be shooting for the moon to try to get as close to that gap, closing that gap as possible.
Dr. Renee Wegrzyn, thank you so much for joining me today and for leaving us with that positive and inspiring message.
Absolutely. Thank you. Take care.
I'll be back soon with Dr. Eric Topol.
Welcome. Today, we'll be discussing the path forward for early cancer screening for marginalized populations. My name is Dr. Gladys Rodriguez. I am a medical oncologist at the Star Center for Cancer Care, and I specialize in treatment of patients with breast cancer. I also serve on the board of directors of ASCO, and I'm humbled to be the first Latina in the board. As a Latina oncologist, since early in my career, I had focused on improving oncology care for those of marginalized or minority populations. And about 30 years ago, I was honored to meet and collaborate with Dr. Amelie Ramirez, who is joining me today in this discussion.
Thank you so much, Gladys. It's a pleasure to be here with you. My name is Dr. Amelie Ramirez, and I am Professor and Chair of Population Health Sciences at UT Health San Antonio. My area of expertise is in behavioral health and health communications. And I've been working in this area for many years now, with a special focus on the Latino community and helping them understand the importance of prevention. And so we have focused on a lot of different cancer education programs and different strategies to try to make a difference in our population. So today I'd like to ask Gladys. Gladys, with all that you've done, can you tell us a little bit about why it's really important to do early screening so that we can help our population, especially those that are living with cancer?
Yeah, for patients diagnosed with cancer, we know that the earlier the diagnosis, the better the survival. The smaller the tumor, the less aggressive treatment somebody needs. So they need less surgery, less chemotherapy, less radiation. And we know that the earlier it is, the better they live, the less likely that the cancer will come back and they will need additional aggressive treatment. And there are some interventions that has been proven to improve that survival. Mammography, for example, for breast cancer, colonoscopy, or the use of ctDNA for colon cancer screening. And then for those that had history of smoking and quit smoking, you had to quit smoking, the use of CT of the chest, low dose CT chest to diagnose lung cancer early. And again, the earlier it is, the better for the patient, less treatment and better survival outcomes. So I know that you had done a lot of work in understanding what kind of interventions are effective in improving screening. Could you share some of those with us?
Yes, well, one of the reasons we went into this work is that, we find that cancer has now become the leading cause of death for Latinos, even though their incidence may be lower. We're finding that they're waiting too long, and so therefore they're being diagnosed at much later stages, and sometimes those treatments may not work for them. And so that's why, again, that early screening is so important. So some of the work that we have focused on is both at the community level and also at the in-clinic level. And we utilize both mass media communications, where we use cultural approaches in English and Spanish in reaching our population, but we have also found it to be very effective to work with community health workers. And these are individuals from the community who have volunteered to say they want to do more for their communities. And we train them on different subject matters. And we find that when we pair community education and outreach through mass media, radio, television, newspaper, and now social media, and pair them with a community health worker, we get more people interested in coming in for screening. And then we said, if this is working at the community level, can we make it work for us in the clinic level? And so we actually found that placing a community health worker in the clinic, along with a physician and PAs and other individuals, that this was still someone that it was easier for the patients to relate to. And we saw that they were more likely to keep their appointments and be consistent about coming in for their screenings. And now the third level, we are working with our primary care clinics, looking at social determinants of health to see who needs a little bit of extra help to come in for screening, but also find out those who haven't been screened for all the different areas that you just mentioned. And so then our community health worker, the physician puts that person in what we call the basket, and then our community health worker can follow up with that patient to encourage them to come in and make an appointment for screening. So that these are some of the techniques that we have found to be very helpful.
Yes, this is very important because, as you mentioned, although the incidence of cancer in the Latino population and also in the Black American population is lower than the non-Hispanic whites, the mortality is a lot higher for both populations. The Hispanic population is the fastest growing minority group. And thereafter, this will impact the overall survival of our communities if we don't do interventions earlier to improve those. I also want to mention that for the Latino population, the highest mortality are associated with infectious related cancer, cervical cancer and human papilloma virus, and liver cancer and hepatitis C virus, for both of which there are now interventions in terms of vaccine therapy and screening that it's not used at the same level for minorities or underserved populations.
And, you know, we're making such a big difference too, right? In working with our clinicians and the importance of better understanding if some of our clinicians have, you know, certain cultural biases that may affect how they communicate with their patients, and really encouraging them to look at themselves. We all carry some kind of bias, and it's important for us to do self-assessments about ourselves and to better understand how we're communicating with our patients and our community. So these are just some of the new techniques that we're implementing. So can you talk about any other approaches?
Yes, definitely. So part of my work has been in improving the number of underrepresented physicians that are Latino or underserved community. I'm funding research grants, research opportunities, programs for rotations and we're actually now reaching to high school level and early college, because if we don't have more physicians that look like the patients that they're serving, we're not doing the best possible. So in that respect, I think that there's a lot to do, and we look forward to continue doing so.
Yeah, no, what great discussion, right? We need to continue doing more. And now I'd like to turn it over to the Washington Post.
Instead of having to turn to the doctor, to be able to get some preliminary advice and put your data, not just a Google search which tells you about the general population, but here's my data, GPT X. Now what do I do? And so there's going to be a lot of this. Of course, this is why we need the regulatory oversight, because it has to work well. If it gives bad recommendations, that could be dangerous.
Hello, for those of you just joining us, I'm Frances Steed Sellers, a senior writer here at the Washington Post. And I am delighted now to be joined by cardiologist, Dr. Eric Topol, who is the Executive Vice President of Scripps Research. Dr. Topol, a very warm welcome to Washington Post Live.
Thanks so much, Francis. Great to be with you.
And I have to say, I'm also a great fan of your Ground Truth Substack. And I know there you sometimes post interviews, so I'm looking forward to turning the tables on you.
Yeah, this I think was a really interesting one I put together on cancer, which might have piqued some interest about why we need to completely upend the way we screen for cancer today.
So I want to ask you first, Dr. Topol, about a book you wrote in 2019, which was called, let me get the title right, How Artificial Intelligence Can Make Healthcare Human Again. When you look back 5 years on, do you think, whoa, I was right back then?
Well, yeah, the actual title was Deep Medicine, and the whole idea is that we could use AI to bring back the humanity, the humaneness in medicine. We're not there yet by any means, Francis, but eventually I do think we have that potential. Back then, we didn't have these so-called large language models that could bring in, whether it's images, text, and speech, audio together. And now we're seeing that, and soon we're going to have the entire corpus of medical knowledge in real time, up to date. So this is going to bring information at a level that we've never seen before at our fingertips. And that I think will help us as long as we get it right.
So you're talking in a way about, 5 years ago, we weren't thinking about generative AI or these huge models that are transforming things now. So update me a little bit. For many of us, it was sort of last November when we became aware of generative AI. Obviously, it had been around before that, but it was a massive transformational movement and interest among the general public. What does it mean for medicine?
Well, it has profound implications. So up until, as you said, the release of ChatGPT end of November, a year ago, we didn't really see these so-called transformer models take hold. They were incubating for these 5 or 6 years, but we didn't see them in action. And what they have done is actually quite extraordinary, because when you get to the level of GPT-4, which has over 1 trillion connections. Our brain has 100 trillion, but this is 1 trillion connections, and it uses massive computing power, over 25,000 graphic processing units. So it can take in, the human content, not just Wikipedia and hundreds of thousands of books and the internet content. And now, of course, it's also with GPT-4 doing this with images and audio. So you have this extraordinary amount of content, which even now hasn't been trained specifically for medicine. But it's turned out, because it has so much of the medical literature in it, that it's providing us a resource that's just quite extraordinary. The question is, how are we going to use this properly? How are patients going to access this to get much better results than they can get currently from a search on the internet? And also, how can it change the life for doctors and nurses as they care for patients?
So let's step back from that question a bit, because we've had AI around for quite a long time and doctors have been using it. So give me a couple of examples of how it has already transformed, either cancer diagnosis or treatment. Just a couple of real everyday examples from a doctor.
Sure. Well, one big one is that, the very difficult cancer diagnoses to make, like pancreatic is a good example, or ovarian, where they typically show up when a patient has got already pretty advanced metastatic cancer, and the chance of getting recovery, preventing this from being terminal, is very low. But now what we've seen are studies that look at the electronic health records, what's in the formal record or what's even in the unstructured text, and they're able to predict the risk so much better. And that's just the electronic health record that someone is at risk for, let's say, pancreatic cancer. Then when you start to fold in other layers of data like the genome, so-called polygenic risk score, or the gut microbiome, you start to get to levels of prediction to define who's at high risk that we never would have anticipated, and it's happening very quickly. And this is really encouraging.
So we've just done a big project at the Washington Post about life expectancy. And one of the things we learned when doing that reporting was how people are developing cancers younger, bowel cancers, for example, in very young people. How do you see AI helping us to reverse this decline? This is all part of the decline in life expectancy, to help us reverse that process, particularly with these cancers which are emerging sooner with young people.
Well, Francis, I'm so glad you asked about that, because this really is a serious issue. I mean, we're seeing people in their 20s with colon cancer and women in their 20s or 30s with breast cancer, and it's increasing, as you pointed out in your Washington Post series. And the problem we have is cancer screening is so dumbed down. It uses age as the sole criterion, but it doesn't acknowledge that some people are at risk at much earlier ages for manifesting, serious forms of cancer. So we have to change our whole mindset that it's just a simple matter of age, because most people at a given age are not really at risk for cancer. Oftentimes age 50 now for breast cancer, mammography starting at age 40. There's a lot of waste in our cancer screening. And instead, we don't define, which we can today, people at increased risk. And that's the way we could find out that some young people have exceptional high risk and start getting over this very primitive notion that it's just age as a sole criterion.
So I want to talk to you a little bit more about regulation, because we're talking very optimistically about what AI can do. And I know you have had concerns about the FDA having, I think you used the term shortcuts. Tell us a little about what you meant with that and what risks you see even as we evaluate these extraordinary innovations.
Right. Well, this is a real sore point, because we have almost 650 AI algorithms. They're all essentially pre-transformer. They're not generative AI. They're the deep learning phase of AI that preceded this. But almost all these algorithms are from companies that have never published the data. So it's completely opaque. Most of it is retrospective. It's not tested in the real world of caring for patients. The medical community doesn't ever get to see it. It's so-called proprietary. The data sets are often weak. And so the criteria at the FDA for granting clearance or approval for AI in healthcare has been dreadfully low. And that's not a good harbinger of where things will go now that we're into this new phase of multimodal generative AI, which could complicate matters further. So we have to tighten up the criteria and get more compelling evidence, because overall we're seeing very low implementation in healthcare systems, partly because we can't see the data. And also, when we can, it's not the kind that would drive a wide-scale adoption. So we need better research, and we need tightening up at the FDA.
So Eric, one of the things I hear from people who write in all the time is concerned about health equities. You've raised it, our previous speaker did. When it comes to AI, we're feeding in data from the past. We know that it has inherent biases in it. Aren't we at a huge risk of just perpetuating and maybe even expanding on the problems we have if we're feeding in data from the past?
Well, the key thing you just said is the problems we have. It's not the AI fault. It's that we have such embedded deep cultural biases. So we don't want to blame AI on that per se, but we do have to revise our way of evaluating the inputs, how the bias could affect what comes out of these algorithms. And that takes very careful interrogation and scrutiny, and not to use any of these algorithms before that has been thoroughly interrogated. So We've seen lapses in that in the past, and that's something we can't tolerate. Part of this will be improved when we have really great, diverse uh, data sets that go into the formation. And like I said earlier, a lot of the things that have been used by the FDA are very small, non-diverse, that is, from the people. So we've got to do better there.
Which brings me to another question about technology, because it used to be that clinical trials really only accepted people who were close to large medical centers. Everything required people to go in. And now we're beginning to see, particularly after COVID, clinical trials expanding to be done remotely. I mean, I think there was one out of Yale recently that's entirely remote. Is this the kind of innovation that could really change the diversity of people coming into clinical trials and change cancer screening and
Absolutely, Francis. We've been a big proponent of this for several years because when you can enroll people through smartphone apps and the web, you reach people that previously you wouldn't get to be participants, whether it's rural, whether it's the diversity. And so we've seen this to be not only a great way to accelerate medical research, but also to make it much less expensive and a far better and larger participant pool. So this is the wave of the future. At the moment, it isn't used so much to test things like a new drug or a new device, but that's where it's headed, and not so much the reliance and the great expense and all the dysfunction that occurs in health systems to get these research projects done.
You mentioned pancreatic cancer, you've talked about colon cancer and breast cancer during. If you were to guess where the next great breakthrough is going to happen in cancer through AI or another technological innovation, let's not stop just with AI, where's your greatest hope?
Well, I think cancer is ripe for, this upending. And I know you're well aware of these multi-cancer early detection tests where you get from a tube of blood in someone who's healthy, you can find cell-free tumor DNA that's circulating in the plasma. And then you can analyze that if the person, may have unsuspected early cancer long before it would be ever seen by a scan. So when you start to be able to pick up cancer so early, and you can also define people who are at risk, not just by age, of course, as we discussed, and we have these potent ways to rev up the immune system to squash whatever early cancer before it even has a chance to proliferate or spread. This is a recipe or a blueprint, if you will, for really changing the fate of cancer. We didn't have this capability. And of course, these tests that are just now starting to become available, they're misdirected. I mean, the yield of the test that has the most use so far, with over 100,000 people using age 50 as the criteria, again, is only finding 5 out of 1,000 people who have unsuspected cancer in their blood. And half of those people are with advanced cancer, where finding it is not as helpful as when you find it extremely early, like stage 1 or 2. So we have to find the people at risk and then use the tools that we have, and we can do far better for prospects in the future for preventing cancer and preventing its adverse outcomes.
Which takes me straight to a question I wanted to ask you about primary care, and it's one I posed to Director Wegrzyn, and that is that in this country, we're seeing a decline of people having primary care doctors. We're seeing a decline in doctors going into primary care. And unless we improve those things, how are we ever going to get people into screenings? Is there a way that AI and technology can help with these almost pre-primary care problems and identifying problems before they come to the doctor's office?
Well, we do need ways to make the efficiency for each physician better, and also their lives better. As you know, the morale, the burnout crisis that's global, but particularly here in the US, we've got to deal with this. And this is, again, where AI can really make a difference. It already is starting to, by getting rid of the data clerk function and moving us towards keyboard liberation, so that when doctors see patients, they can actually see them and spend time with them and cue in and listen to them. This is something that every physician, particularly primary care physicians, want to do, but they've been so burdened as data clerks, not just in the midst of seeing patients, not even having, face-to-face, eye-to-eye contact, but also with hours of this kind of work after seeing them at the end of the day or in the evening. So this is a real problem. We've got to make the lives of physicians better so they are really caring for patients. And that will attract more people to go into primary care. Plus, it will make the morale, which is low, it'll make it so much better. This is part of that improving the humanity in medicine for patients as well as for clinicians.
So Eric, a couple of weeks ago on this show, I was lucky enough to talk to a doctor about a system that essentially provided you with avatar doctors available 24/7 for your primary care. I think $15 a month. When I can't reach my primary care doctor, it sounds very inviting. Is that the way of the future? It marries AI with this huge problem we've identified in primary care.
Well, I don't know that that's the real solution, Francis, but I do think doctor-less screening of common conditions, whether it be a rash or a lesion or a urinary tract infection, even heart arrhythmias through smartwatch detection, and ear infections in children, and a long list. We're seeing AI making very accurate diagnoses. And so that would, of course, diffuse the contact, make it much more practical and timely and inexpensive to get the answers to then if a treatment is needed or oversight is needed by a physician. So we're going to see more charge taken by patients, more autonomy. Whether avatars will fit into that remains to be seen, but all these things require very careful, rigorous prospective studies to validate that they work well. And we're starting to see that now, and that's also a very positive sign.
So you had your book 5 years ago. You essentially were predicting the future then. Predict the future for me is the last question. Take me 5 years from now. What do you see and with this huge change in innovation?
Well, I do think we're moving to a whole different type of medicine where if we get the gift of time and reboot the patient-doctor relationship, which has had serious erosion, that would be the overarching goal, so that we can restore this vital presence and trust and compassion and empathy, which is what patients are wanting. So if I had to project, 5 years from now, not only will we improve accuracy using these large language models, generative AI, and being able to make diagnoses more accurately, particularly when they're complex. But my fondest hope, the one that we really have to keep our clear-eyed objective, is to get back this relationship, which has suffered so much because of the issues that we've had to grapple with. So let's hope that we can do that.
Let's hope we can reboot the doctor-patient relationship. Dr. Eric Topol, thank you so much for joining me on Washington Post Live.
Thank you, Francis.
And thank you also to our viewers. As you know, for further program, you can look at WashingtonPostLive.com. We've got a great lineup coming, including a Global Women's Summit next week. So don't miss any of that. I'm Frances Steed Sellers from the Washington Post.